we're going to move on in the book and start talking about antihyperlipidemics, or drugs that will help improve cholesterol deposits in the circulatory system. So this is covered on pages 134 to 138. Here you see a graphic that I found, and on the left top is a picture of a quote-unquote normal artery. It's a cross-section, and you see the lumen of the artery. It's unimpeded, very smooth. To the right, there has started to be a little bit of plaque buildup. As cholesterol starts to accumulate, it begins to grow under the lining of that lumen, and it will cause a roughness in the wall of the artery that wasn't there before. As the high cholesterol proceeds, you've got a bigger buildup of the cholesterol plaques around the inside of the artery. It gets rougher and rougher. And of course, we know that if a red blood cell encounters something that is rough or scratchy, it can be damaged, and a damaged blood cell wants to turn into a clot. So it will stick to that roughened place, and then platelets will begin to gather around it and make these cells all clump together, and eventually you can end up with a clot that can impede circulation to the heart, the brain, vital organs, and then you're kind of in trouble, because then the circulation is definitely not getting to your heart. Now, we need cholesterol. It's something that helps us build very strong cell membranes that will withstand pressure. It also helps us to make hormones and steroids that we need for our body. But if the cholesterol builds up and isn't needed for cell membrane production and making various chemicals in the body, then it builds up in the bloodstream to where it can be what we call too much, and then we can end up with increased cholesterol. So there are 4 types of what we call lipoproteins, or kind of fatty proteins. One is a basic fatty protein called a chylomicron, usually made up of triglycerides, and this is formed directly from us absorbing fat through our intestines. Then we go into the formation of what are called VLDLs, or very low density lipoproteins. And so a lot of these triglycerides that are absorbed in the intestine, everything kind of gets in the liver, and the VLDLs are made out of this abundance of triglycerides. And eventually, after the triglycerides are made in the liver, they begin to move into the blood itself. And there we develop 2 types of lipoproteins, or what we call good and bad cholesterol. So we have low density lipoproteins, or LDLs, and they kind of refer to that as bad cholesterol because that tends to be formed out of a breakdown of the very low density lipoproteins, and you get a mixture of proteins and cholesterols that can really accumulate and clog up the arteries. And then we have what's known as HDLs, or high density lipoproteins, the quote unquote good cholesterol. And these sort of act as almost vacuum cleaners, cleaning up dust bunnies. So we've got the LDLs kind of serving as dust bunnies, and the HDLs that sort of help keep them cleaned up. And they help to clear out excess cholesterol from your tissues and hope to prevent a buildup that can lead to that situation that we saw in the previous slide. I'm going to scan a handout called the Lipid Lowdown, and I want you to kind of look at what it's made up of and what the correct count should be when it comes to taking a total cholesterol, how much you should have of each type of cholesterol. So In page 136 in the textbook, we start talking about the various kinds of anti-cholesterol drugs. And probably the most common anti-cholesterol drug now, and this has its own table on page 136, is a category called the HMG-CoA reductase inhibitors. So they lower low-density lipoprotein levels by slowing down the production of cholesterol in the liver. They don't remove the cholesterol that you eat, but they do stop the liver from producing as much. All of these drugs end in statin, which is a lot easier to say than HMG-CoA reductase inhibitors. So most of the time you're just going to hear them referred to as the statins. They're very effective on LDL levels. I call them the statin sisters because they all have, statin as their last name, but atorvastatin is our prototype drug, and that's known as Lipitor, one of the most commonly sold drugs now in our pharmacopoeia. And the statin sisters work in the liver just to cut down on the buildup of LDL. However, because they work in the liver, it can affect the liver, especially if you have a tendency toward possibly liver failure. And so regular liver function tests have to be done to make sure you're coping with it. And you want to avoid alcohol because these drugs do a number on the liver. You don't want to compound it by drinking alcohol, which can also damage the liver. If a pregnant woman is taking this, a developing fetus needs lots and lots and lots of fats. I cannot tell you the importance of fats in the proper development of fetuses, infants, and small children. Their brains depend on a proper amount of fat, all their hormones, all their cells. So we don't worry about fat in fetuses and small children. They need it. And so if you restrict the cholesterol in a pregnant woman, eventually the cholesterol in a fetus is going to be affected, and proper brain development, proper cell growth, everything can be badly affected. So a pregnant woman should not take statins. One of the complaints that people have about the statins is that it causes a lot of arthritis type symptoms. Somebody might complain of sore joints and muscles. Eventually that's supposed to go away as you become more accustomed to this medication. If it does not, and if it becomes worse, that can be a sign of muscle breakdown, or what we call rhabdomyolysis, that can eventually affect the kidneys. And so the healthcare provider needs to be notified if that muscle soreness just continues.